Morning.
Hey, Jake.
How it goes? And sorry, I don't think I ever asked, like, do I pronounce it like Nare?
Yeah, Nare.
Nare, okay, good.
Yeah.
I didn't notice the accent before, but yeah, okay.
Like the right way to say it is Nare. Like
Okay.
you roll the R, but I don't expect everybody to roll their R.
Okay.
So Nare.
I'll do that though.
Nare in French.
If that's the right way to do it, then I'll do it that way.
All right.
We'll just wait just a few minutes.
Yeah, that's not a problem. I don't think it'll be 30 minutes unless people ask a lot of questions, but
Cool.
it's like a 20 to 25 minute presentation.
That sounds good. Oh, we got a bunch coming, right? All at the same time now. Great.
$902 seems to be the
Yeah. Oh, like, they got the popcorn, got some pop. They're ready. It's a big show, so. I'll say 9:03. That's when we'll pull the curtains. Okay. All right. So welcome everybody to rounds. It's been a while since we've had actual rounds. So welcome back. So to start the morning, we have Nade, who's going to tell us if pink ladies can put out fires.
Awesome. Thank you. So let me share my screen. Do you see it in the slideshow format?
Yeah, slideshow format, it's full screen. Yeah.
Perfect. And you can hear me?
Yes.
Awesome. Okay. Good morning, everybody. So I'm Nare. I'm one of the R3s in the CCFP EM program. And today I'll be presenting my critical appraisal topic. So basically the title is pink lady necessary to put out a fire? So let's dive right in. So let's start with a case. So this is a case I just had a few weeks ago. I'm sure everybody here has had multiple similar cases. So basically, it was a 51-year-old female. She was presenting with epigastric discomfort / dyspepsia. She described it as a burning sensation. It was new for the past few days. It was constant, non-colicky. Review of systems was otherwise negative, so no cardio-resp symptoms, no melena, no nausea, no vomiting, no fever. Really, that was about it. And on physical exam, she had some epigastric discomfort, and she looked, but otherwise, exam was unremarkable. So my POCUS was normal, even including the gallbladder. And so basically, what I do for her, and also a relevant history for her, she recently took naproxen for a shoulder injury. She's also a smoker, and she said maybe her dad had esophageal cancer. She's not sure. So I order my workup. I order a CBC, LFTs, lipase. Because of her age and the location, I also include an ACS workup, but I don't order any imaging for now. And since she's uncomfortable, when I got her supine, the burning got worse. She was burping. She looked a little like this guy over here, not that bad, but a little. So I wanted to relieve her by the time I wait for my results back. So I decided to give her a Pink Lady. So the reason I gave Pink Lady is because, I don't know, I've seen staff give it and I'm like, okay, monkey see, monkey do, let me just give Pink Lady. And then my staff turns to me and said, what are you doing? Why are you giving Pink Lady? That's so old school. And I don't know, being called old school in your negative 1 year of practice is a bit bizarre. So I decided to look more deeper into this subject. So we'll come later back to our case. So maybe some of you are wondering what a Pink Lady is. So a Pink Lady is basically an alcoholic beverage. It's pink. There's a cherry on top. No, I'm kidding. I know it's very early for this. It's an eye opener. But the Pink Lady that I'm talking about is the GI cocktail. So basically the mix of an aluminum magnesium hydroxide solution, like Malox, for example. By the way, I'm going to call it Malox sometimes, Malox sometimes, just bear with me. So it's basically Malox mixed with viscous lidocaine, which is pink, hence the pink color. Whoever thought of this in the past probably got inspired by the alcoholic beverage and hence why it's called that. There's a whole Wikipedia page for some reason on the Pink Lady cocktail if you guys are into that at 9 in the morning. So just a bit of background, everybody knows this. Epigastric pain, dyspepsia, it's a very common chief complaint in the emergency department. I'm sure you've all seen it. Just a recap of things we saw in med school. This is a table from the Tintinelli. Abdominal pain is a visceral type of pain. So when it's in the epigastric area, it can represent the stomach, the proximal small bladder, small bowel, not bladder, liver, gallbladder, pancreas. Hence why the differential diagnosis is so broad. So it can be gastritis, it can be some form of flare-up of GERD, peptic ulcer disease. It can be esophagitis, biliary colic, pancreatitis, gastroenteritis, hepatitis, neoplasm. It can be a lot of stuff. And I also include ACS, obviously, in the workup in the right patient population and the right clinical scenario. So the initial treatment in emergency departments is it can vary a lot within departments and within physicians. Some give antacids alone, like I mentioned, magnesium aluminum hydroxide alone, just so basically Malox or Gaviscon or Sucralfate. Some, like me, give the Pink Lady, so the antacid with a mix of viscous lidocaine. Others might give, I don't know, PPI, a H2 receptor antagonist, and obviously remember to stop the offending agent. So stop the naproxen or the Advil that's causing the symptoms, or the spicy curry, you know what I mean? So which brings me to my clinical question. So is antacid combined with lidocaine, so Pink Lady basically, is it more effective in relieving epigastric pain than just antacid monotherapy alone? So this is the question I'm going to try to answer through this presentation. So when I was searching for it, before I talk about the article that I'm going to focus on specifically, just a quick literature review on what's been done before. These are all American studies. So Welling and all, back in 1990, decades ago, a century ago, this was done in Kansas City. So they did a single blind study comparing lidocaine versus antacid monotherapy. And they found that adding lidocaine actually significantly increased pain relief. So they recommended giving the pink lady. But this article has been since criticized for the fact that it was single blinded. So there was a huge bias. The interviewers were not blinded. They knew what medication they were giving to their patients when they were retrieving the data. And then 13 years later, Berman and al., this time it was in Philadelphia in 2003, they did a double-blind randomized controlled trial with 113 patients. Basically, they compared antacid monotherapy versus antacid with an anticholinergic. It was Donatal specifically, and versus antacid with an anticholinergic with viscous lidocaine. So some version of pink lady, including an anticholinergic, like an antispasmodic. And they found basically that there was all treatments had similar pain relief. So all treatments had clinical efficacy, and there was no statistical difference in pain relief. So their conclusion was, might as well just give antacid monotherapy. There's no point in giving the pink lady. And then the third one doesn't really answer my specific question per se, but I found it interesting. So Vilke and al., this was done in San Diego in 2004. So they did a single blind RCT comparing antacid with benzocaine, so a type of anesthetic, versus antacid with lidocaine, basically pink lady. And they found that there was no difference between the two. But there was no antacid monotherapy group. So again, doesn't really answer my question. By the way, if anybody has any questions, I don't really see the comments, the chat box. So
not yet. Nope.
Awesome. All right. Which brings me to the article that I will be dissecting today. So it's an Australian study published in the Academic Emergency Medicine Journal in September of 2020. So done by Warren and al. And the title is basically antacid monotherapy is more effective in relieving epigastric pain than in combination with lidocaine, a randomized double-blind clinical trial. So let's get into it. So just an overview of the article. I divided it in the PICO format. So the population that they're studying are basically adults that come in with very broad symptoms of epigastric pain / dyspepsia, presenting to the emergency room, obviously. Patients that were included were patients under 18 and who were unable to consent. And they compared 3 groups. So the intervention group was the pink lady group. So they basically received 10 milliliters of viscous lidocaine mixed with 10 milliliters of antacid. And the antacid they used was, again, like a hydroxide, aluminum magnesium hydroxide solution. It was basically an equivalent of Malox. They call it gastrogel in that part of the world. I don't know if anybody has done any rotations in Australia, but that's what they call it there. So that's the pink lady group. And they compared it to a solution group. So again, 10 milliliters of antacid, of gastrogel, mixed with lidocaine liquid this time, versus the third group, an antacid monotherapy group, but 20 milliliters of the antacid this time. The outcomes that they were looking for were, so primary outcome was a change in their pain score on their visual analog scale at 30 minutes post-treatment. So basically, they're seeing what their pain relief is 30 minutes post-treatment. And the secondary outcome is same thing, but at 60 minutes post-medication administration. and also adverse events. And a secondary outcome that they were measuring, again on that same visual analog scale that I'll show you in just a sec. They were also measuring medication palatability. So the taste, bitterness, texture, overall acceptability of the medication. I'm just gonna, in my words, describe to you what methods they used. By the way, this is the visual analog scale that I was talking about. So patients would score their pain from 0 to 100, 100 being intolerable pain. So the study was done in the Royal Melbourne Hospital. It's a tertiary adult center. So it was a single center study. It was done over 3 months in 2019. And again, it was randomized and double blind. So what happened exactly was whenever the emerge doc had to prescribe an antacid or a pink lady, regardless of what the final etiology was going to be, the moment they put that prescription in, research assistants were paged, and they brought a pre-randomized envelope containing instructions on which medication to prepare. So either the antacid monotherapy or the antacid plus lidocaine viscous, so pink lady, or the antacid with lidocaine juice, like liquid. So nursing was aware. So this envelope was given to the nurses so they can prepare the medication. So the nurses were basically aware of what medication they were giving. But all in all, the patient, the doctors, the investigators were all blind. And then right before taking the medication, when the patient consented, obviously, to the study, they would score their pain on the analog scale. So at time 0, like right before taking. And then at 30 minutes post-medication ingestion, and then at 60 minutes. And they also obviously scored for the secondary outcomes. They scored the taste, the texture, the bitterness, and the acceptability, the overall acceptability of the medication on the analog scale. Any questions on the method so far? We're good. I'll take that as a no. Okay, all right.
Yeah, no questions as of yet.
Okay, perfect. So, okay, this is a heavy slide. We're not going to go through all these little numbers. Basically, this is table 1 of the study, which is a very important table, as we know. So here, there's a lot of patient characteristics that they describe, and they also describe the outcomes like in the lower section of their results, basically in the lower section of the table. So just a bit, I'll give you details about the patient characteristics. So overall, 89 patients were analyzed, and there was 30 in the pink lady group, 31 in the liquid lidocaine group, and 28 in the antacid monotherapy group. Each group had around like 2/3 of each group were females. The average age was in the early 40s, like for each group. And interesting to note that around 80% of each group had like a final diagnosis of a GI-related etiology at discharge. So there's more patient characteristics in the middle that I'm going to touch on later slides. We'll decipher all those. And here we have our results. So basically, what are the results they found? Also interesting to see that the initial pain score is quite similar. It's in the 60s for each group. So it's nice to see that we have a similar starting point. But at the end of the day, they're analyzing the delta in the change in the pain score. So the primary outcome, so again, reminder, primary outcome is that change of pain score at 30 minutes. So you can clearly see that antacid monotherapy seems to have given the most pain relief compared to pink lady, for example. So 20 points versus 9 versus 17. So this is a clinically significant difference between antacid and pink lady. But again, it's not statistically significant when you look at the p-value. And then again, similar findings at 60 minutes. So antacid monotherapy gave further relief, but again, not statistically significant differences between all 3 groups. And then our secondary outcomes. So the taste. So antacid monotherapy seems to be the yummiest, and the less bitter, and has the best texture, and overall the most acceptable one. And some of these are actually statistically significant, like the taste and the bitterness. the taste and the bitterness and the overall acceptability. So all in all, just in one phrase, all three groups had pain relief that was not statistically significant, that was not significantly statistically different between all of them. And also antacid monotherapy group seemed to have the most acceptability in terms of taste and bitterness and overall acceptability, and that was actually statistically significant. All right, so now is the part where I'm going to try to analyze, well, critically appraise this topic, okay? So whenever I'm trying to dissect an article, a study, I'm asking myself, what is the internal validity of this article? So right off the bat, this study is randomized and double blind. Like, we love those words. So in theory, there should not be any types of selection bias or observer bias if it's properly randomized and double blinded. In my opinion, I think it's properly randomized. First of all, there was no difference in terms of loss of follow-up in between groups. Actually, there was actually no loss of follow-up between the groups at all. So, I mean, the fact that they just had to follow them for 60 minutes probably explains that, but nobody was lost to follow-up. And when I looked at the patient characteristics overall, groups look quite similar. But here, I'm just going to try to attempt to find, I'm really going to nitpick on, try to criticize about, try to find stuff that's wrong with the article. So for example, like, is there a selection bias? So let's say, this is a detail I didn't mention before, but the patients were recruited between 8 a.m. and 11 p.m. So night shift patients were not recruited at all. So I'm just asking myself, could the overnight patient clientele have changed anything could they have impacted in any way the results? I don't have the answer for this. The authors don't really touch this point. I mean, patients at night are sicker. There's some ETOH involved. They're more supine. And I don't know, they'd probably be less inclined to participate in scoring their pain relief, like on an analog scale. But when I think about it, I mean, the efficacy of a medication shouldn't differ whether it's given at night or in the morning, because at the end of the day, they were studying the delta of like pain relief, right? If anybody has any opinions, feel free. But again, like I said, I don't have the answer for it. The authors don't really touch on this. And then I asked myself, are the groups unbalanced? So again, in table 1, the groups seemed very comparable, except for one point that I noticed. The lidocaine groups seem to have more of a prior upper GI related diagnoses. Like, I'll just show you right here. So let's say acid related, like GERD, peptic ulcer disease, gastritis, like the lidocaine groups, 7 people, 8 people, versus like half of the amount of people in the antacid monotherapy group. So I wonder, could it have, could the lidocaine, could those people be more resistant to pain relief? Could they be more resistant to analgesia? Is that why my antacid group seems to have more of an analgesic effect? Is that why their change in pain relief was more clinically significant? Again, the authors don't really comment on this, so it's just a question, like a detail that I picked up. And then, could there be an observer bias? I mean, like I mentioned, the nurses were not blinded, and the authors actually do comment on this. So they really emphasize the fact that nursing was not involved in data collection. The people who were meant to be blinded were blinded. So patients, the doctors, and mainly the research assistants that were gathering the data. And also the solutions were not made to look identical. Like literally one solution's pink and the other one's like translucent. And they also comment on this in the article. It's really, they didn't want to alter, they didn't want to tamper with the solutions. They didn't want to change the color or the texture, because one of their secondary outcomes that they were looking for is with literally texture, taste, and overall acceptability. So this was the sacrifice that was made. It's really a give or take. Since they really wanted to analyze that, they didn't try to make them look identical. But the volume was the same. So the whole point of that was to make patients swallow the same amount of medication in all three groups. But I just have to comment on the fact that the monotherapy group had 20 cc's of antacid versus the lidocaine groups had 10 cc's of antacid plus 10 cc's of lidocaine, either gel or solution. So the authors argued actually that there was no, so the recommended therapeutic dose of the antacid of gastrogel or even Malox here, the one we use, is 10 to 20 cc's anyway. And there was no studies comparing dose response curves between antacids. So whether it be 10 or 20, they say that there shouldn't be a difference in terms of pain relief, because since they're part of the, since it's in the range of therapeutic dose. Any comments so far?
There was just a question about the data. Is there any data on the actual time to onset of pain relief? That's from Dr. Doyle. Just like, so it's 30 minutes and 60 minutes, but is there anything that talked about?
Like how long they've been having the symptoms?
Or like how long it took for the pain relief to start, I believe. Like
within those first 30 minutes?
Yeah, within those first, that's what I think the question is.
No, they don't actually comment on when the person started, like how fast they started having the pain.
Like was it 18 minutes? Data. Yeah, on it. Okay, yeah. Okay.
No, but interesting comment for sure. So overall, I think the randomization and the double blind was, in my opinion, was optimal, and I think the internal validity is okay. This is just me nitpicking. And then external validity. So how much can I generalize this single center study done on the other side of the planet? Can I generalize it to my population? I mean, why not? I mean, I don't know what the differences are, of an urban setting in Australia versus here in Montreal. In my opinion, it could probably be applied to our population. But again, I'm just speculating. But I like the fact that they cast like a large net when recruiting patients. So basically anybody with epigastric discomfort, regardless of their etiology, whoever needed Malox or Pink Lady were included in the study during those 3 months. And I feel like it's reflective of general practice. So they didn't really try to standardize their inclusion criteria. So it was basically anybody with these symptoms. So bottom line, their conclusion was there was no difference in pain relief when it comes to antacid monotherapy versus Pink Lady versus the liquid lidocaine group. And the way they phrased it, so a 20 milliliter dose of antacid alone is no different in analgesic efficacy than a 20 milliliter mixture of antacid and lidocaine, either viscous or solution. And also the antacid monotherapy was more palatable and acceptable to patients. So overall, their conclusion is Pink Lady, there's no added benefit in giving it. Might as well just give the antacid monotherapy. The Pink Lady, probably more expensive. It's less palatable. It's more yucky in a 3-year-old language. And overall, it's not evidence-based as per this study. So change in practice is recommended. Just use antacid monotherapy alone. And I'm very curious to see, especially if there's staff in the audience, if they still use it or if they've ditched this entirely, if they think it's old school or not.
There,
yeah, go ahead.
Sorry, there's a comment from Dr. Myers who, so it doesn't make sense to sacrifice a primary outcome for a secondary one. But I see no way to mask the taste or feeling of drinking lidocaine. So I think the reason they didn't blind the patients is because they couldn't. And then she continued by saying, I stopped when I learned this a while back. So yeah,
makes a lot of sense. And also I didn't mention adverse effects that there was more adverse effects in the lidocaine group. So there was oral numbness in 20% of the pink lady group and 26% in the liquid group. So I guess the liquid lidocaine is more prone to giving oral numbness. And two patients in the viscous group had dizziness, 4 people in the solution group had cough, nausea, and only 1 patient had side effects in the antacid monotherapy group, and it was like oral dryness. But definitely like 1 out of 5, 1 out of 4 patients in the lidocaine groups felt like this type of oral numbness. And they don't really comment on this, but I'm just like thinking if they're numbing the throat and, you know, that might affect the gag reflex, like is there a danger giving this to older clientele? Is there, especially if they're supine, if we wouldn't want them to aspirate, especially if they're having nausea, vomiting, if they have pancreatitis or bad gastritis. Just something to think about before giving an elderly patient PO lidocaine. So quickly back to our case. So our 51-year-old lady, the investigations were unremarkable, including the EKG and the trope. She was relieved with the antacid monotherapy with Maalox, 15 cc times 1. And my working diagnosis at that point was basically gastritis, likely exacerbated or triggered from her naproxen use. So I discharged her with a PPI prescription. But for her, I specifically decided that I'm going to refer her to an outpatient G-scope. She had some alarm features, like her age, she was a smoker, there was possibly that history of GI malignancy in her family, like 1st degree. Her symptoms were new. And here, just a recap. This is a table from the Tintinelli. Just a reminder for you all. Alarm features for endoscopy, like patients over 50, new onset, B symptoms, dysphagia, obviously like melena or like anemia, if they have a mass, and of course, family history. And I gave her return instructions that kind of reflect these alarm features also, you know, B symptoms, dysphagia, and all that. And that's it. These are the pink ladies from the movie Grease, 1978. If anybody has seen, if you haven't seen it, don't watch it. It's not good. And that's it.
I watched it a while ago, and that was the only time I saw it. I have a question. Just if you could go back to that table, like the table that has the results and stuff. It already kind of goes into this, but I'm just curious if they sort of if they associated so let's say the discharge diagnosis is GI versus cardiac versus other.
Yeah.
Did they analyze how the pain scores would improve, let's say in a cardiac patient? I just think it's something that we talk about where, you know, someone's having epigastric pain and then we give them an antacid and it improves their pain. Does that actually say that they are not having cardiac pain? And I'm just curious if
I was so sure somebody was going to ask this question. I knew it. So they don't comment on this. So I don't have the data through this study to see if it's going to help more in cardiac patient or in a GI patient. But man, I wish I kept the article, the study that I had found. I probably closed it because I cleaned my desktop in case somebody sees my desktop and judges me. But basically in literature, as we know, it's very controversial, and when we give lidocaine to try to differentiate if it's cardiac or GI, it's not evidence-based basically. So there was no proof that it's actually helpful in helping with our clinical acumen and in differentiating cardiac versus GI etiology. But no, to answer your specific question, the authors, they don't comment on this and they don't make that point.
We have kind of a shorter morning, so there are a few more questions from the group. So actually, Johan, are you willing to talk? Because it's kind of a longer comment. I can read out the whole thing too if you want.
I can talk, Jake. So great presentation, Nari, by the way. I just feel like it's really, I found it was a really weird choice that they decided to give double the antacid dose to one group compared to, you know, just 10 milliliters on the other. And since the nurses weren't blinded anyways, they knew what they were giving.
Yeah.
Like, did they why did they want 20 milliliters so badly when they could have just given 20 milliliters plus lidocaine compared to just a 20 milliliter group of antacid? Because that's what we do here, if I'm not mistaken, or at least what I saw in my previous rotations was like 30 milliliter Malox plus lidocaine, or just 30 milliliters Malox or whatever.
Yeah. So they really wanted it to be the same volumes, right? So you're saying, why didn't they do like 20 cc's antacid everybody, and the lidocaine groups have like extra juice? Is that what you're saying?
Yeah, and because if they wanted the same milliliters because they wanted the person giving the medication to be blinded, I get that.
No, it's so they wanted it to be the same volume it's because of for the patient acceptability. Like, I don't know about you, I'd prefer to drink 20 cc's compared to 30 cc's of like this medication, right? So there might have been like a confounding factor, or not a confounding factor, but maybe bias from the patient's point of view. They might accept the smaller volume more than the larger volume. So they really wanted all volumes to be equal. And the antacid monotherapy group had 20 cc's, and their argument was whether it be 10 cc's or 20 cc's, it's still in the therapeutic range. And there is no proof that there is this form of that 20 cc's is more of an antacid relief than 10 cc's. So there's no studies on dose response curves in terms for antacids. Does it answer your question or not really?
It answers my question, but it's just I feel like it's like,
yeah, like it's not perfect. And
yeah.
they made that sacrifice because, again, they wanted to study that secondary outcome. But like Dr. Myers had said, it's weird to sacrifice your primary outcome for your secondary outcome. But en tout cas, yeah.
Thank you so much.
I think now, so great job. Lots of discussion points. So thanks so much.
My pleasure. Thank you. Anne is next, right?
Yes, correct.
Yes. Let me
Hi,
share.
Anne. Good morning.
Good morning. Great presentation.
Yeah, I'm stopping. Okay.
Let me share my screen. I was just saying that Nari should make videos for Dr. Glaucom Flecken. I never know if I say his name properly. Okay. So I guess we'll just start. So I'm doing, I guess, not as a riveting topic, but hopefully by the end of my presentation, you'll all think that it was interesting and that the landscape's kind of changing. So hopefully you take something from it. We're going to be talking about antibiotic dose and duration for community-acquired pneumonia in the pediatric population today. And it's based off of the Capit trial. And we'll go through 2 other trials that actually came out in the past year as well. So let's take a step back. Let's go back, I would say probably 20 years. You're in the emergency room and you see this really cute kiddo who happens to also be one of our CCFP Emerge residents. You can take a guess as to who it is in the chat if you'd like. She's really cute, but she's coming in with fever, cough, runny nose. You listen to her chest, you hear some crackles, some decreased air entry, and you think to yourself, okay, it's probably a pneumonia. I'm going to treat it with amoxicillin. But what dose and what duration should I treat for? And I just want to take a little poll. If you can all go to menti.com and just put in this number at the bottom left, and then choose one of the 4 options. So really the difference between the options are the dose and then the number of days of treatment for amoxicillin. And let me just pull up, I'm going to stop sharing and then share the actual poll. And for those of you who are in bed, you can also just use menti.com on your phone as well. Let's see if it's working. Oh, press C. Let me just see.
Anne, can you share the code for the poll again?
Oh, yes. So it's 8079 1161. Let me know if you need me to repeat it.
It's on the top of the page.
Oh, yes. Good point as well. I don't know if you've all been able to vote and it's just not working. Okay, it's working. I'll just give it a few more seconds. Okay, so I'll keep this up just for a few more seconds. It seems like, so it's interesting actually. I was thinking that most people would have chosen the 90 milligrams per kilo per day for 7 to 10 days, which it seems like the majority has, but there is a proportion that are using the lower dose of treatment. And we'll go through the different trials that have come out, and then you can make your decision the next time you see a kiddo with a pneumonia and what you're going to treat with. So yeah, the majority here chose the higher duration and the higher dose. So just remember that and keep that in the back of your mind. So let's just go back to our slides. So the IDSA guidelines in 2011 actually recommend amoxicillin 90 milligrams per kilo per day. So that's a higher dose for a treatment duration of 10 days. And these are guidelines from 2011. At the children's, the majority of what I've seen, and correct me if I'm wrong if other people have seen other things, but it's the higher dose, the 90 milligrams per kilo per day, usually for 7 to 10 days as well. So in keeping with the IDSA guidelines. But where do these guidelines really come from? So the original studies actually come all the way back to the 1940s, and they actually found that the duration of treatment was effective for, if they were treating with amoxicillin, for 2 to 4 days. And then their fear really was, and they note that in the articles, was there was a fear of treatment failure, especially in the pediatric population. So that's why they actually ended up treating for longer, for 7 to 10 days. But the evidence at that time was 3 to 4 days was effective. Then when medical historians actually went back in the studies to see what our guidelines are based off of, it seems like one of the biggest studies was actually from 1945. So that was really years ago. And that was a study based in the New England Journal of Medicine. And what they were looking at, they were going to treat with antibiotics until there was a definitive clinical improvement. So that means really no symptoms, no fever, no cough, as well as a temperature below 100 degrees Fahrenheit for 12 hours. And then what they said was, again, because there was this fear of treatment failure, was let's just treat for another 2 to 3 days. So as you can see, these studies are not the most robust in quality, I would say, but this is what our guidelines are based off of. So there's really a need for better studies, and this is what we'll go through today. As well, in the 70s, we know that there were some studies that looked at lower dose treatments, so around 30 to 40 milligrams per kilo per day, and they found these to be effective as well. But then with the occurrence of strep pneumo resistance to the penicillins family and amoxicillin, they actually said that duration of treatment should be longer, so 7 to 14 days and higher dose. And that's where our IDSA guidelines came out in 2011. And again, they were really recommending higher dose for longer duration of treatment, which is what many of us, or many of you, chose in the poll. Why do we really care about this? As I said, not the most interesting topic to some, but we know that worldwide pneumonia is the leading cause of death in children less than 5 years old. We know that our studies aren't great. We know that the data is not really robust. So there's a need both to examine both the dose and the duration of treatment for this really important disease that we see in children. And that's where this study comes in. It's called the Capit Trial. And over the next 15 minutes, I'm going to try to convince you that it's an important and maybe interesting topic that might change your practice in the future. This actually came out in JAMA Pediatrics in November of 2015. And what they were looking at was whether a lower dose of amoxicillin, so that's 30 to 50 milligrams per kilo per day, is non-inferior to a higher dose, so 70 to 90 milligrams per kilo per day. And then the second variable they were looking at was duration of treatment. So is 3 days non-inferior to 7 days of treatment? So they were really looking at two different variables. And this was actually a study based in the UK. So this is just an overview of the study. What we're going to do is look at each individual part. And if you have any questions, feel free to interrupt as we go on. So let's start with the population. So again, this was a study based in the UK and in Ireland. There were 28 hospitals in the UK and 1 in Ireland. It was a randomized, blinded, placebo-controlled, multi-center. Again, we said it was a non-inferiority clinical trial. And what they were looking at, which is applicable to our population, is patients discharged from the emergency room, as well as patients that had been kind of like, I guess I would say it's kind of like our short stay units. So patients that were admitted for less than 48 hours. In terms of the inclusion criteria, so it's children older than the age of 6 months. And what's interesting to note and to remember, and we'll go through this when we actually appraise the trial, is that their diagnosis of pneumonia was really based off of a clinical diagnosis. And this is based off the British Thoracic Society guidelines in the UK. So to diagnose pneumonia, they said that there had to be either a parent or guardian reported cough within the previous 96 hours. There had to be a temperature measured above 38 degrees Celsius, or the parents had to report a fever within the previous 48 hours. And there also had to be signs of either labored or difficult breathing. And again, these were patients discharged from the emergency room. And then one important exclusion criteria was that they didn't include any patients with severe disease. So patients that were septic, patients that had pleural complications, as well as patients that were immunocompromised. And then when we look next at what were the interventions. So again, we said that there were 2 different variables that they were looking at: the dose of treatment and then the duration of treatment. So there were 4 groups that these patients could be randomized to. And you can see the 4 doses up on the screen. And then what they were looking at in terms of their primary outcome was how many of these patients needed to be retreated with antibiotics within 28 days of their first treatment of antibiotics. That was their primary outcome. And then in terms of secondary outcome, they were looking at 9 reported or parent-reported pneumonia symptoms. So things like cough, fever, anorexia, vomiting, and sleep. And then as well, they were also looking at adherence to treatment. So whether patients continued taking their antibiotics. And then as well, they were looking at adverse events, things like rash, diarrhea. And then finally, they wanted to see whether patients developed strep pneumo resistance. So that they did was they actually did a nasopharyngeal swab at day 0 of treatment. And then 28 days later, they re-swabbed the patients to see if they developed resistance. So what did they find? Oh, sorry. These are the 4 different groups, and the percentages are, again, the percentages of patients in each group that needed to be retreated with antibiotics within the next 28 days. As you can see, the numbers are very similar, which means that for lower dose treatment, so that's the lower dose compared to the higher dose treatment, which is the 90 milligrams per kilo per day, and the lower duration, which is the 3 days versus the 7 days, the low dose, low duration is non-inferior to the high dose, high duration. And what are the secondary outcomes that we spoke about before? So the 9 parent-reported symptoms, so again, those are things like cough, sleep, anorexia. The only one that was statistically significant was cough and sleep. What's interesting to note is that for patients that got lower dose duration of treatment, they actually had cough for 2 extra days. So instead of having cough for 12 days, they had cough for 10 days. Otherwise, in terms of adherence to trial medication, so as you can expect, the patients that had a shorter duration of treatment, 3 days of amoxicillin, actually were more adherent to those that had 7 days of treatment. And again, this was statistically significant. In terms of adverse events, the only one that was statistically significant between the groups was skin rash. So those that had a higher duration of treatment had 27% chance of having a skin rash versus those that had only 3 days of treatment had a 22% chance of having a rash. And then finally, in terms of the resistance patterns, again, I said they swabbed people at day 0 and then at day 28. None of the patients actually developed strep pneumo resistance. So kind of if you weren't listening or you zoned out for part of the presentation, really the important thing to note from this study is they're saying low dose, low duration of treatment was non-inferior to high dose, high duration of treatment of antibiotics for community-acquired pneumonia in pediatrics. What were the strengths of the study? Well, it was a multi-center randomized blinded study design. As well, the primary and secondary endpoints were really patient-oriented. So again, they were looking at parents writing down whether they had cough, how their sleep was, if they were eating or not. So it was really patient oriented. As well, and probably most importantly, as we had discussed earlier in the presentation, was that this really addressed the need. Our studies previously and our guidelines previously were based on not the greatest evidence. And it's an important topic that we need to know how best to treat these patients and for how long we should be treating them for. And again, this is the first study actually that examines both dose and duration of treatment. And these study findings actually fit with 2 other studies that came out this year, and we'll go through those very briefly afterwards. If we critically appraise the topic, we know that this study addresses a clearly focused issue and one that's needed. The cohort was actually recruited in an acceptable way and one that's applicable to us. Again, it's patients discharged from the emergency room as well as from their short stay unit. So that's patients admitted for less than 48 hours, which is going to be what some of us see later on in our practice. Otherwise, it was accurately measured to minimize bias. So patients, again, were randomized in a 1-to-1 ratio, and blinding was achieved by, for those that needed higher doses or longer duration of treatment, what they did was they repackaged their amoxicillin suspension as well as their placebo to look exactly the same and to taste the same. So if anyone's tasted amoxicillin, some people will say that it tastes good, some people will say that it doesn't taste great, but they all tasted the same for these study participants. And the follow-up was also quite good. 97% of patients were actually followed up all the way to day 28. So that's quite good. What were the limitations? So I think this was a really important point and probably one of the biggest limitations of this topic or this trial. If those of you are on the Twitter world, you know, or even if you're not on the Twitter world, you know, Dr. Carr, he actually very recently tweeted out that shorted antibiotic studies for community-acquired pneumonia. 3 days. Does that mean most are viral? And I mean, I don't know what the right verb is, but he added or he mentioned Dr. Bogosh, which I'm sure many of you know as kind of our ID expert. Specifically, we see him a lot during COVID on TV, but Dr. Carr makes a very good point that many of these patients actually may have a mixed pattern of disease. They may not have bacterial pneumonia. They may never have needed antibiotics in the first place. The criteria that they're using, and the authors do mention this in their discussion point, is when they're trying to diagnose pneumonia, it's really based out of, again, a clinical diagnosis. They're not using laboratory or chest x-rays to make their diagnosis. But they also note that even if you have laboratory biomarkers, so things like a CRP, or you even have a chest x-ray, it's not always reliable to differentiate a viral versus a bacterial pneumonia from those investigations. So it's very possible that many of these patients that we're treating never needed antibiotics in the first place. The other limitation that we have to think about is the rate of retreatment is actually quite high in all 4 groups. So 12% needed retreatment with antibiotics in the next 28 days. So it raises a question as to whether we should be rethinking how we both diagnose and treat these lower respiratory tract infections in our kiddos. Other limitations, well, again, we said that the way that they actually looked at the primary and secondary outcomes were really patient-oriented and were subjective. So there was a high chance of measurement and recall bias. Another important point to remember was that many of these, or all of these patients did not have severe disease. So that was part of their exclusion criteria. So it's important to remember that you can't extrapolate this data to patients that may be immunocompromised or may be sicker with a pneumonia. And then probably one of the more important points that I wanted to bring up was one of the secondary outcomes that was statistically significant was cough and sleep. So cough and sleep for the lower duration of treatment was actually longer. So for those of them that only got 3 days of treatment with antibiotics, they ended up having cough for 12 days instead of the 10 days of cough for those that had longer duration of treatment. You know, 2 days is not a big deal when we think about it. It's written down 2-day difference. Doesn't seem like a big difference, but for those parents in the group or who have had to babysit a child that has been sick, those 2 days with cough means that the child may not be sleeping because they're coughing all night. Their child might not be drinking or eating because they're coughing all night, which then means the parent's not sleeping, the parent's not eating. So those 2 days may make a big difference to the parents. And that's where kind of that shared decision making comes in, and speaking with the patients about what's best for them and what they would like. And I said that there were 2 other trials that came out this year as well. So it seems like there's been kind of a huge wave this year. I'm not sure why, but clearly there was a need to look into what is the best dose and duration of treatment for for pneumonia in kiddos. So there were 3 trials that came out this year, actually, or in 2021 and then 2022. The first study was actually called the SAFER trial. All of the studies actually came out in JAMA Pediatrics. The SAFER trial was, I think it came out in March of 2021. And that was looking at just the duration of treatment for antibiotics. And they were looking at a non-inferiority margin. So they looked at 5 days versus 10 days, and that they found that 5 days was actually non-inferior to 10 days. So again, showing that a shorter duration of treatment was non-inferior to a longer duration of treatment. Then came our study, which we just spoke about. So the Capit trial, that came out in November of 2021. So we had March 2021, then November 2021 was the Capit trial. And then finally in January of 2022 came out the Scout Cap trial. And again, in the JAMA Pediatrics, they were looking again at 5 days of treatment versus 10 days of treatment. And they were actually looking that 5 days was superior to 10 days of treatment for pneumonia in kiddos. And they found that it was superior. So these were 3 really high quality RCTs that all came out in the past year. And they all showed that either lower duration of treatment or lower dose was either non-inferior or superior. So the guidelines probably won't change right away, but we do see that this pendulum is kind of shifting. There will be a need for larger, more prospective international randomized control trials that will come out. But it's important for us to realize that things may be changing and that you can decide whether you want to change your practice or not. Again, the guidelines haven't changed quite yet, but things may be moving. So one question to think about, the next time you see, one of these kiddos, this would have to be 20 years ago as well. 2 of our other CCFP emerge residents, please guess who's who. But the next time you see them, a sick kiddo, they come in, they have a fever, they have a cough, your exam shows that they probably have a pneumonia. What are you going to treat them with? Are you going to keep treating them with kind of what you've already been doing, or are you going to change your practice a bit with what the new evidence shows? And again, that's really up for you to decide. That's up to kind of the standard of care at the hospital you're working at, but it's a discussion that might be interesting to note with your colleagues and with the parents as well. So that's it. If anyone has any questions, feel free to let me know. I'll stop sharing.
One question that came up was
yes.
The follow-up period. So I believe the study was the first month, like the first 28 days. Was that I think at the beginning, like looking at recurrence of infection? Yeah. Was there any like longer follow-up, like in the months afterwards, or was it limited to about 30 days?
It was a 28 days only in their study. Yeah. Okay.
And another question, I think I just missed this in terms of how they were divided into groups. So it was the low dose and high dose, as well as the 3 days and the 7 days. Were each of the dose groups divided into short and long term as well? Okay.
Exactly. Okay. Yeah, there were 4 different groups.
Okay. Let me see if there aren't any other questions at this time. Not even about the baby photo. So
I'm just gonna keep this here then. Okay, so I'll stop sharing.
Awesome. Okay. Any other questions before we take a break? Perfect. Okay. Thanks so much, Anne. Great presentation. Very thorough. All right. So we will come back. A bit of a shorter morning this morning, but we'll come back at 10:15. Okay. 10:15. Hi, Val.
Morning, how are you?
Good, good. How about you?
Sorry?
How are you?
Oh, very good. Thank
Good.
you.
Awesome.
The audio's all right?
Yes. Yeah, I believe so. I can't see them right now,
Excellent.
but alrighty. Great. So we'll get set. So welcome back, everybody. So now we have Dr. Vallomier, who's going to give us an exciting talk on Code Orange.
I'm just putting it in the right format. Sorry.
Yeah, no worries.
Yeah, I think we're good now.
Yeah, it's presenter mode and
Yes,
full
you
screen.
confirm?
Yeah.
Okay. Hi, everyone. So I'm bringing you a little bit outside of COVID now, as much as possible. This is overdue. So it's my pleasure today to discuss with you a few elements pertaining the preparation towards disaster simulations, which I think is useful information wherever you will work in the future, because these will continue to occur. And there are some important elements to know when getting involved in such a project. Why are we putting this on the round schedule? It's because we have one coming up. For those who didn't know, we have secured a date on May 12, 2022. So please mark it in your calendars, all the residents. I want you there. We haven't done anything for the last 2 years for preparation for disaster simulation, not in a type of setting where we have a lot of people together and we have an actual simulation with a whole setup. So this is a date to mark, May 12th.
It's a Thursday. It's a Thursday. It's for everyone to, if it wasn't known yet.
Yeah, thank you, Jake, for pointing that out. So it's not a typical Wednesday. Why? Because we need a dedicated day for this, and it has to be outside rounds for different reasons. So you'll get 2 for 1 that week. So it's going to be really exciting. My objectives with this short lecture here are to go over the different types of disaster simulations that exist that you can do in a healthcare facility, go over some preparation steps that are essential, and discuss some golden rules, maybe some pitfalls to avoid to ensure a simulation is very effective. So I'm not doing this alone. Absolutely not. We have a wonderful team. All the R3s are going to bring you on this road to the simulation with me. So it starts today, this preparation for you guys, for the participants. It's important to understand that you cannot come to a disaster exercise unprepared and expect that you will come out of it fully prepared and ready to manage anything that comes through your door. So this is the concept that I want to hammer home, I guess, is that it's a process. It's not a single day, okay? So I want you to embark on this journey, and this is going to be a train that we get on, and there's going to be something almost every week. Nothing taking a lot of time, but just keeping your mind fresh so that on May 12th, you arrive to the simulation and you're absolutely prepared and you take the most out of the experience, because it's a lot of preparation. We cannot do this every week, but we definitely could do it more often. Okay, so the objectives here, again, some information for the R3s organizing and also for you as those who are going to graduate from this program and potentially be asked to participate in such exercises in the future. So what are the different types of simulations we can conduct? What are some necessary preparation steps? And again, some golden rules and pitfalls to avoid to ensure that your training is effective. So there's a lot of myth and reality in this domain. There's a series of myths that have been repeated over time. For example, that it's actually impossible to be prepared to face a disaster simulation. Maybe the government is the one who should take care of it, and actually they will, and so we should let things go. That maybe a single generic or a standardized course can do the trick. For example, you register to ACLS and you are certified to do resuscitation. We all know that there's way more to that. There's always new literature, there's new techniques, new tools, there's new uses for ultrasound in that context. So that's what I'm saying. A single generic course is not sufficient. An occasional sim once in a while would be sufficient to refresh your memory and be prepared? Absolutely not. Actually, that's what I find my colleagues report to me as being most stressful regarding Code Orange is, how am I going to remember everything I'm supposed to do? Okay. So there's this notion that you have to remember a super thick protocol and execute it. So that's also part of one of the myths. It's true there are some basic concepts that you have to have in mind, just in general. And I guess those I will talk about today, but there's a lot that is adaptation and decision-making. So for all the R3s listening, we have to remember we are trying to train our learners to make decision under limited information and under new circumstances. There are many challenges, obviously, associated with disaster medicine training or emergency preparedness training. And you can see this fish trying to jump out of the bowl. It sounds like maybe going to lose the challenge here and not make it quite in the next bowl. So definitely many challenges. One of the problems is that there are long delays between the training and the actual real event. We do a sim on May 12th, and then who knows when's the next time you're going to respond to an event, and it may not be exactly the same thing that what you had in your simulation. Not always true. The day that the first Paris attack occurred, they had been training for a scenario very similar to what occurred that evening. So most of the time this is true, but there are a few exceptions. Responding to a particular disaster situation requires adaptability and identifying new solutions. So obviously there's no universal protocol or recipe. We all agree with that. Those who receive training are not necessarily those who will be responding to the real situation. That's true. That's one of the challenges when you organize a simulation in situ, so inside the hospital, inside the emergency department, for example, if we're going through the emerge, well, you cannot have the whole department there on duty at the same time. And so unfortunately, that's a problem. Ideally, we should repeat the simulation for 1 month so that everybody can actually get the experience. But that is one of the things I have found very difficult over time, is to give that amazing experience to many people at the same time. There are solutions to improve that, but it's never the same as when you're the one answering the call, or actually you're the one having to make all these decisions. Training is often based on response plans, which are often based on wrong assumptions. Yes, that's true. One of the things is that disaster response plans seem to always assume that the sickest patient will come later, and they will come all packaged by EMS, and that you will have time to plan for the arrival of the sickest patients. So it would be nice. We'd like to think that it's that way. And yes, theoretically, if you are a proximity hospital close to the disaster, yes, you'd like to think that all the less sick patient will come walking, yes, but it's absolutely possible that you get sick patients that are coming by Uber or coming some different ways. So you cannot assume that, for example, it's just an example I'm giving, that you will never get a sick patient before long in the process, okay? But often there are these kinds of assumptions in the plans. This is an important publication from 2017. I went to check, and there's not a new version available, but it's still quite current. It's not something that completely changed still then. It's free. It's downloadable online. I think everyone interested in organizing simulation in general, not just for disasters, should go and download this document. There are different types of exercises which we will learn in this manual. So some are based on discussion, for example, a tabletop where you sit around, you have a scenario, and there are specific questions directed at the group. There are also operational exercises. It can be a drill, a functional exercise, or a full-scale exercise. So what's the difference between those three ones? So a drill, you're looking to practice a skill. For example, I would like you to be able to perform donning and doffing of decon equipment. That's a drill. A functional exercise, you're trying to test a part of a response plan. For example, I would like you to be better at triage, or I want you to be able to perform disaster triage. Then that will be a functional exercises with that specific goal. And a full-scale exercise is when you're deploying the full protocol, we're trying to respond, and we're involving multiple outside agencies. So there you go, and collaborate also with other agencies, full scale. So decon drill. This is an example to illustrate what I was just talking about. What's a drill? Here we're practicing how to do actually the cleaning of an unconscious patient who is unable to walk, and therefore you need 3 people to actually help that patient do it. So, and you can see the patient is on a backboard to facilitate bringing the patient out of the roller. I remember this specific drill. We realized there's certain problems here with this process of taking an unconscious patient and bringing the patient on the roller. It's not as simple as it seems. It's easy to get hurt. Everything is slippery, and it's easy to drop the patient. And, you know, this is equipment that we don't deploy every day. So this was extremely useful to practice, okay? There's another type of drill, which is, again, just a specific task when you make sure you are practicing how to call back your team members. If you need to have a surge of personnel, you want to call them back. How do you do that in an efficient way? Okay, they're doing a calling tree. Not everyone does calling tree anymore, but there's still quite an important method used. And here it's a drill, again, to practice using a manual patient tracking method. Okay, if you don't practice, you can't do it. Okay, so these are all important elements that are part of a disaster response plan. Okay, and then here tracking, key element of response. And this is an example of a full-scale exercise that happened in 2017 involving the airport, and they had multiple agencies involved. And they had a shooter in the airport, and they practiced managing patients, like people that are traveling in the airport. They had to get the police in, identify the shooter, and they had to evacuate the victims. So they did the whole thing. Okay, so that's where you would have an example of a full-scale exercise. Okay, in 2012, we also did a full-scale exercise. I'm sure you will recognize our colleague, Dr. Levan, who will never forget this day because it was, I think, her first day back from maternity leave. So that was quite a challenge. So this was a full-scale exercise in the sense that we had an external agency, paramedics, bringing the patients. We had our full protocol deployed, and every step of the protocol was activated as opposed to just a small part of it. So we did the triage. So this is an important slide, is you don't take someone who has never been trained for responding to a disaster situation to take them from nothing and put them in the full scale exercise. I guess you could, but it could be, first of all, traumatizing, and also it will not maximize the learning experience because they don't have the basic knowledge first. So this is arrow here. This arrow is exactly what we're talking about. This is why this talk is called The Road to the Simulation. So we're going to bring you on this road together with the R3s, and there'll be some milestones, things to learn between now and May 12. our concept is that we don't want to add a burden. We want this to be fun. We want this to be something you're looking forward to when you get a new piece of information. You know it won't be long. You know it's going to be maybe funny, maybe exciting, but certainly entertaining. And we're hoping that every week you'll remember that there's May 12th coming and that you're looking forward to it. And you know a little bit what we want you to learn from this whole training process. Okay, so this, you see here, the level of preparation required. So if you're going to do a full scale exercise, you need ideally to have done all the smaller exercises before, ideally, to be able to prepare. We will do our best. It's difficult for us to follow exactly each step and organize several training exercises, but we are very creative and we'll make sure that you have sufficient information before you start on May 12th. This is a busy slide. The goal is just for you in the future one day when you are hoping to prepare for a training exercise, you will remember to choose the type of exercise based on the needs. If your nursing team wants to practice the triage, or if another group of providers, paramedics that you're working with want to practice triage, you will probably pick a drill exercise after you did formal training on the actual protocols. But if you want, for example, to explore a little bit what are the needs for a specific department learning, you might organize first, a tabletop, a discussion, and see where the problems are, and then from there build your training based on what are you trying to teach people. Okay, so you have to see what is needed. For our simulation on May 12th, I can tell you we are not going to sit in front of Zoom. Okay, so you'll be fully involved, and we are hoping to at least get ourselves to the blue section, a functional exercise. Okay, so definitely it'll be interesting. Okay, this is a little bit more of a planning slide, what needs to happen when you are organizing a disaster simulation. So basically, of course, there is basic planning. What are the goals? What is the scope? What are we trying to achieve? And then obviously there's a need to set up a team and material as well. You have the delivery, and then very important, you need to do closure and see what went well, what did not, and how you can improve in the future. I'm talking improving the actual simulation and also improving the response plans. Okay, so this is, all of this needs to be done in order to have a successful exercise. Okay, so now I'm just gonna take a little pause, and Jake, I'm just gonna ask you to unmute if that's okay. So this is an important slide here that I just always like to make sure we cover. So this is from public safety. Okay, across Canada, they have this concept of this wheel that's turning all the time. And so basically in here, we have an actual real incident, which is the black area. This is what we're trying to prepare for. So right now, we are in the blue section with regards to what we're trying to achieve. Okay, so we're in the preparedness phase. And so it's a wheel that keeps turning. So let's take the incident, just an example. The incident is the COVID-19 pandemic was not over, but certainly you can adjust at this point how you responded. Okay, you've done the response in orange, and you can recover. You can see a little bit what needs to be improved. Okay, mitigation, the yellow section, is going to be a part where you're always surveilling what is coming next. What are some risks that are coming? For example, I'll just give you a small example. When I was an R1, this is back in 2005, we were not talking so much about computer failures and cybersecurity and such. It was existing concepts, but didn't seem to be part of our concerns as much as it is now for disaster preparedness. Now, this is definitely a bigger risk. And this is something that all healthcare institutions, given the importance of the computers and the computer system, definitely we need to plan for that, okay? All right, so Jake, I would like to see with you if it's possible to somehow use the chat or something, and maybe I just wanted you to facilitate that if possible, okay? So basically when we talk about mitigation and prevention, and so basically the yellow section, we're talking about, you know, thinking about our risks associated with a particular environment. So I wanted just to open up the chat, make sure that there is some participation here for everyone. I don't know if I'll need you, Jake, really, but anyway, just in case. So the question for everyone is, if I position you in the Glen site, okay? This is the biggest building for the MUHC. If you think of the location of it, what are some of the vulnerabilities or the types, that's more clear. What are the types of disasters that you should be preparing for? Based on the actual location, thinking which city, what's associated with the city, what's around. And so I would just like to have that brainstorm happening in the chat. So it's open to everyone. What are the things that you think we should be preparing for when you position yourself in the Glen site?
The metro accident is coming. This is coming from the chat. So yeah,
Okay.
near metro, car accidents near our highway, Descaries viaduct collapse. Yeah, lots of highways around big accidents, infrastructure. So lots of references to highway and metro. And train accident because the above ground.
Somebody said shooter in the main cafeteria.
Yeah, explosions, fires, gun violence, high school shootings, chemical threats, anthrax.
Okay.
Old Port industrial accident.
Okay, good. Excellent. Okay, so everybody wants to know what are we going to be doing on May 12th, right? Okay, well, I'm not going to give you the answer, but that was good, actually. I thought that people are doing some, there's more, Jake?
Nick enthusiastically says natural disaster, exclamation point.
We've
Radioactive
had tornadoes
disaster.
in the last years. We've had multiple different things. And just to make sure, what is the most common disaster in the whole world? What happens most commonly? Somebody for the chat? Rita, you have to come out of pandemic. I said natural disaster. Well, I guess it was natural, but the answer, yes, Yuan, you got it. Floods. This is the most common natural disaster worldwide. Okay, definitely. So we have had floods in 2017, 2019 before also, but those were the really bad ones. Yes, we've had ice storms here. We've had heat wave. We've had tornadoes. We've had a pandemic, yes. And we've had a lot of shootings. We've had a lot. So it just, sometimes we don't always, not one person is involved in every event. So we don't realize, but they're quite common. Okay, excellent. I see that you get it. So we're preparing for different types of risks. And I really want everyone to be clear. When you have a small number of opportunities for training, you pick to train for the highest risks associated with your locality. Okay, so for us here in Montreal, to train for a volcano eruption is nice to make a scenario like that. It's creative, but maybe not based on what are the needs. Okay, so always start from the beginning. What do we need to train for? And put your money there. Okay, let's keep moving because I want to show you a video at the end. Thank you for participating in the chat. Okay, here, very important, evaluation during the exercise. I'm not sure I like the word evaluation because I find that may create a stress, but we certainly have to look at how people are responding during the event and learn from that, okay? So people observing learn as much as those participating. So it's very important that you have people there watching what's happening. You shouldn't impede the flow of the simulation. Let the participants play, but you need to have a way, either some cameras or some people there observing key elements to make sure what hasn't worked. And if you want my experience, what often doesn't work is the patient tracking. That's a huge problem. And why? Because we don't practice it. So you can be certain that we're gonna do that on May 12th. It's important to know who's coming in, who's going where, what's happening, or else you don't know the needs. You don't know what you're supposed to, prepare, what are the next steps, the OR, the blood, everything. You need to be tracking properly what's happening. So be prepared to do that. You need to give sufficient time for debrief because you've been through a lot. There's a lot of emotion. There's a lot of exposure. There's a lot to say. I have myself, and I've said it before, been involved in a large-scale simulation with very little debrief after, and still to this day, I have a lot of memories from that. Some good, but some like a lot of stress associated with it. So this is not something we should take lightly. People should be able to have a proper way out of the simulation, not to leave with so much exposure that wasn't debriefed. I'm not sure that's very good. Okay, so yeah, these are some pictures here. Okay, full scale exercises. Okay, so this was with no lights. Okay, so that's an added challenge when you can't see anything. Okay. All right. There are many phases to the feedback, which I keep repeating is important. A hot wash right after, right this minute with your little team that you're involved with, a hot wash, discuss a little bit what was difficult, what went well, what not. And then there's a main debrief with all those that are belonging there, those who participated, the organizers, all that. There should be food, there should be sufficient time, there should be at the end closure certificates ideally, and a separate debrief for those who are organizing. Okay, so try to understand everybody here at one point will be in a position where they're either participating or organizing or evaluating as part of the McGill EM training and this program that you're doing. You will go on and be involved in this in the future. So it's important to know a little bit the basics of that. I'm going to skip the financial aspects and leave you, before I show you a short video, if Jake will allow me, the keys to a successful exercise. Start planning in advance, obtain authorizations. Okay, you don't just say, oh, we're doing a simulation and nobody's aware. So for us, we have authorization from Dr. Poirier, the program director. We have authorization from Dr. Khalil for helping out with the simulation center team. So we are, not doing this blindly. We're creating a multidisciplinary team. We don't want just residents training alone. We're going to get some partners with us, some multidisciplinary participants. And these people need to be organized through reps. Okay, so every organization should have a representative. There's a budget, you need to follow it. Funding is essential. And pick the date early. Whatever you do, this is not just for disaster preparedness. I would say in life in general. If you want to achieve anything, pick the date early and put it in your calendar. Okay, practical exercises must be integrated into a training program. You got it. You're not just going to show up to May 12th and think that the knowledge will come to you and you do nothing and you come out of there and you're fully prepped. No, it's a road and we're going to help you on this road. It should be a very interesting journey. Disaster medicine is a team sport. There's different types of healthcare providers. I do not support exercises only with a specific type of provider because that's never how it's going to go in real life. And no notice exercises, I hadn't mentioned that, but they are encouraged. But you should do that only when you have done basic training before and drills and exercises. No notice at this point after a pandemic, I do not encourage. A lot of new personnel, few people have gotten training we haven't done in many months. So announced. You know the date. It's May 12th. You don't want to miss it. I'm going to leave you with a video of a very interesting sim that we organized in collaboration with the MGH Foundation. Few people have seen that video, but I'm just going to show it and I'll be done after. So it's like 1 minute, I think. Jake, is that okay? All right.
Yeah, absolutely.
I have to find it. Oh boy. Okay, 1 second. It's here. I have it. It's just that it started playing, and so now I have to put it back for 2 seconds. Okay, well, let me do my best here. I'm just going to share the screen the best I can. Okay. I decided to stop there because the audio wasn't working, I'm told. Someone sent me an SMS. So I don't know why. Maybe I'll send it to you and you can show it. I'm sorry for that, but at least you saw a little bit the setup and you could see that. Okay, so I'm gonna stop here because my time is up. And
Oh, still a great video. So thanks so much, Val. Yeah, exciting. We're still working out the scenarios and such, but it's looking to be somewhat epic. All right, so we'll move on. So next presentation is Rada, who's going to give us his grand rounds topic.
Hey, good morning, everyone. First off, I want to apologize. My camera, for some reason, is not working, so You won't be able to see my morning face, unfortunately. Can
It sounds like you're lying.
Okay?
I feel like you're lying. But yeah, no, you can go ahead and share your screen.
Okay. It's,
that looks good.
It looks good? All right. So good morning, everyone. My name is Rita. I'm one of the second-year emerge residents. And this morning I decided to talk about mechanical ventilation. I feel it's a very important topic for us because as emerge residents, we all enjoy intubating patients, but we often don't see the patients when they go into the ICU and how they're managed while intubated. So briefly, I'm just going to show you this diagram that shows you how diverse treating an intubated patient can be. It varies, like it's a multidisciplinary approach, and it varies from clinician experience. It's a patient-centered approach. It's got multiple ways of monitoring the patient, adjusting for either malfunctions or pretty much monitoring the patient in general. Is very intensive, hence the intensive care unit. Requires like nurses and RTs, as well as the clinicians. So just a brief introduction on the presentation. I'm going to be talking basically about lung volumes, ventilation perfusion, VQ mismatch, ventilator parameters, ventilator modes. And at the end, I have a couple of case examples that I kind of created. It's meant to be interactive at the end, so whoever wants to answer, feel free to answer. So just basically about lung volumes. So the average human male has around 6 liters total lung capacity. And I don't know if you can see my pointer here, but these two lines here just basically shows the tidal volume, which is around 500 milliliters in the average male, or 6 milliliters per kilogram. So basically during inspiration, our negative alveolar pressure sucks air into the lungs. And during expiration, the positive alveolar pressure pushes air out, basically. So as you can see, the lungs are highly adaptive, either in times of stress or in times of exercise, or in sick patients or intubated patients, where we have a lot of room for adjustment based on the patient's needs. I won't go into too much details about calculating each parameter of the lung volume. In terms of ventilation and perfusion, the alveolar minute ventilation is around 4 liters per minute, and the perfusion is basically the cardiac output, which is 5 liters per minute. So calculating the VQ ratio is simple. It's just the alveolar minute ventilation over cardiac output, which gives us a 0.8 quotient. Ideally, in a perfectly matched patient, VQ should equal 1, but it's never such the case. So the overall VQ in the human lung is around 0.8. And just to understand that how gravity can affect these changes in ventilation and perfusion. So the pleural pressure is increased at the base of the lungs, resulting in a more compliant alveoli and increased ventilation. And the hydrostatic pressure is decreased at the apex of the lung, resulting in a decreased flow and decreased perfusion. So for example, if you're standing up straight, the VQ ratio is around 3 at the apex of the lungs, whereas at the base, it's around 0.6. So all this to say is that ventilation exceeds perfusion towards the apex, and perfusion exceeds ventilation towards the base. I'm going to explain basically the west lung zones, so it's going to help explain why that is as well. So on the diagram on the right, you can see up top, the perfusion is absent, whereas zone 2, the perfusion is sporadic, and this is where we kind of want to be to meet our respiratory coefficients. Zone 3, where the perfusion is constant. And you can see on the left is the pressure. So the alveolar pressure in zone 1 is the highest, arterial pressure and the venous pressure. Zone 2, where you get the arterial pressure, is higher than the alveolar pressure, where you get most of your gas exchange. And zone 3, you get your alveolar pressure is dead last. So you have a higher incidence of shunting, which is basically perfusion without ventilation. And in zone 1, you get the highest incidence of dead space, which is ventilation without perfusion. So VQ mismatch is kind of a spectrum, or it is a spectrum from 0 to infinity. And the lower the VQ is, the more shunting you get, and this is most commonly seen in like airway obstruction, pneumonia, infections, multiple causes. And as you go along the spectrum, you get wasted ventilation when the VQ is higher. Where it's seen as basically anything that blocks the blood supply to the capillaries. So like a PE or a massive cardiogenic shock. So VQ is the gold standard to get this ventilation perfusion ratio, but like we often don't do it just to get the ratio. It's only done if you're thinking of a PE, and you can't do a CTPE study for obvious reasons. And often you can predict the amount of VQ mismatch based on the diagnosis. So just to summarize about VQ mismatch, like shunting, you get a normal blood supply with poor ventilation. And causes include pneumonia, pulmonary edema, tissue trauma, atelectasis, mucus plugging, like multiple causes. With dead space, you have a poor blood supply, but the ventilation is normal. Causes include, like we mentioned before, is cardiovascular shock, emphysema, and PEs. So how does this relate to mechanical ventilators? So in mechanical ventilation, it can do two things as well. So it can increase dead space. So the positive pressure ventilation increases the alveolar dead space, which then increases the alveoli that do not have the corresponding increase in perfusion. So that can actually worsen the VQ mismatch and create more hypercapnia. Whereas it can also reduce a shunt, so an intraparenchymal shunt, by improving the alveolar ventilation. And that can improve VQ matching and oxygenation. So it kind of has pros and cons, and depending on the patient and the case that you have. So moving on, I'm going to speak about like ventilation parameters. So in the emerge, we proceed with intubations, and we're lucky to have RTs that are great, plus our staff that are great as well, to help us set these parameters. And I always found it difficult as to know like what the parameters mean and what kind of modes are we going to use. So having a general understanding of a ventilator is very important, because sometimes we do keep patients overnight in the recess area because there's no beds in ICU. So even though they're admitted under the ICU, they're still under our care in somewhat way. So having an understanding is very important. Jake, I see that there's someone wrote something in the chat. I don't know if that's for me, but feel free to interrupt me at any time.
Yeah, no questions that I'm seeing at this point.
Okay, so, all right. So the first parameter that I'm going to be talking about is tidal volume. So we briefly touched on it, which is the volume of air that goes in and out in one breathing cycle. So in a healthy young male, it's around 500, and a female, it's around 400, or we can use the 6 milliliter per kg. And the ICU, there's like diagrams that predicts like estimated body weight and can give you like a more accurate calculation of the expected tidal volume of that patient. So this can be affected in numerous diseases: restrictive, obstructive, and neuromuscular disease, ARDS. So in a patient that's not intubated, that has restrictive lung disease or neuromuscular disease, the patient adopts a breathing pattern of rapid, shallow breaths to minimize the work of breathing, whereas patients with obstructive lung disease acquire a breathing pattern of deep and slow breaths to minimize the work of breathing. So that's when you can see in patients that are COPD and are intubated, sometimes we prolong their expiratory time just to compensate for their natural breathing pattern. And the next parameter I'm going to talk about is PIP, so peak inspiratory pressure, which is the highest recorded pressure in the respiratory cycle. It can be increased in bronchospasms, secretions, decreased lung compliance, or under sedation. For example, if you have a patient biting down on the ET tube. So just to continue on pressures, the diagram on the right, pressure during the whole cycle. So at the bottom here, we have our PEEP. And during inspiration, our pressure gradually increases until it reaches the peak, which is our peak pressure, and then drops down, which gives us our plateau pressure, which then further drops down during expiration. And that drop here gives us our driving pressure, and it can be calculated by minusing the plateau pressure from the PEEP, or sorry, vice versa. And you get our driving pressure. And we have been leaning towards driving pressure more in the ICU here, maintaining a target of less than 15. So if you see patients in the ICU, all of the patients pretty much must have a target of a driving pressure of less than 15. If you're going more than 15, you kind of have to explain yourself thoroughly because a lot of ICU staff don't like a driving pressure higher than 15. Initially, we used to look at plateau pressure and we used to target it at -30, but we're kind of leaning away from the plateau pressure and more towards the driving pressure. So this was statistical analysis done of the 9 previously reported randomized trials that pretty much took data from around 3,500 patients. So they isolated effects of changes in driving pressure resulting from randomized ventilator settings, and that they noticed that a decrease in driving pressure was strongly associated with increased survival. And there are multiple studies that are also backing up this data. Hence why we're moving towards driving pressures more. The next parameter that I'm going to talk about is Peep, so positive end expiratory pressure. Basically, it's a positive pressure that will remain in the area at the end of a cycle that is greater than the atmospheric pressure. It's very important because it prevents alveolar closure, increases ventilation, and increases lung compliance. So it's a very important pressure to keep, pretty much. So I wrote down a question of like what factors can affect auto PEEP. If anyone wants to answer, or I can proceed and explaining it.
Like underlying disease, like COPD, asthma.
For sure, yeah. Mainly obstructive lung diseases as one thing that can affect our auto PEEP. So just to briefly explain what auto PEEP is. So if you have your flow over time diagram, you have your inspiration, and then you go down to your expiration. So the ideal scenario is you get your expiration in this dotted line that goes back to the baseline at 0. But in auto PEEP, you have a shortened time of expiratory time. So the expiration goes here, and then you get this bit of like air trappings or gas trapping, which can further decompensate the patient. So basically, it's like expiratory time is shorter than the time needed to fully deflate the lungs, preventing the lung and chest wall from reaching an elastic equilibrium point. And as Jake said, it's seen in obstructive disease, COPD, asthma. So how can we correct for auto PEEP?
Maybe expiration-inspiration ratio?
Exactly. So what would you like to do with the inspiration and expiration ratio?
Prolong expiration and decrease inspiration time.
Perfect. So that's one way of doing it. You can also decrease the rest rate and increase the inspiratory flow. So for example, if you have a patient with COPD and you're keeping him breathing at 20 beats per minute, so that's every 3 seconds, he's getting 1 breath. So that's approximately 1 second for inhalation and 2 seconds for exhalation. And COPD patients, as we discussed before, they need this prolonged expiratory time in order to compensate for their CO2 retention and prevent auto PEEP as well. So 2 seconds is not enough. So what we can do is, like Fatma said, is decrease the IE ratio, but also we can decrease the rest rate. So if we, for example, decrease it to 10 beats per minute, 10 breaths per minute, you'll get 1 breath every 6 seconds. So 1 second for inhalation and 5 seconds for exhalation. And this should compensate and bring the line back to its baseline, preventing the auto PEEP. Anyone know if auto PEEP is causing severe respiratory distress or shock, what the quickest way we can do is to normalize the auto PEEP? That's fine, I can give you the answer. So the quickest option is you can actually disconnect the patient from the ventilator and deeply compress down on their chest. So forcing out all the air trapping pretty much, and then reconnect them on the ventilator. So you'll see that the flow will go back to normal. it's a very effective method, but you don't usually do it for like minimal gas trapping. All right, so moving on physiology. So how does Peep affect our physiology? So it can decrease our cardiac output and leads to hypotension, and does that by decreasing the venous return. It reduces also the right ventricular output and left ventricular output, and it does that by compressing the pulmonary vascular bed. Therefore, it increases the pulmonary vascular resistance, so that increases the right ventricular output. And that increase in pulmonary vascular resistance can shift the intraventricular septum towards the left, impairing diastolic filling in the left ventricle, reducing left ventricular output. And in terms of the thorax, it can increase the intrathoracic pressure, obviously, and improve lung functional residual capacity. So PEEP is very good, but it's not without its consequences. And the last two is the FiO2, which are pretty much self-explanatory. So it's a fraction of inspired oxygen. And room air, as we know, is 21% and can be titrated up to 100, depending on our oxygen saturation target. But FiO2, we don't want to keep it up for a long time above 60 because it increases the chances of lung injury from like oxygen-induced lung injury. And Respirate pretty much. It can be adjusted in assist control modes or intermittent and mandatory modes. Which brings us on to the next section, which is the ventilation modes. So you have your assisted control ventilation or CMV, intermittent mandatory ventilation, which I won't be talking much about because we haven't been using it that much in the ICUs or emerge pretty much. So I'll talk about it very briefly, but not for a long time. Spontaneous ventilation, so it includes pressure support and CPAP. So the first one we're going to talk about is the assisted control. So basically, this is when all the breaths are delivered by the ventilator using a preset parameter that we set. So in these, the patient can actually trigger the ventilator to deliver the breaths, but whenever the ventilator is triggered, the parameters that we set, that's the breath that he takes. So it's not based on his breathing. It's just him triggering the ventilator or her triggering the ventilator. It delivers the same amount of preset parameters that we put in. So we have pressure control, volume control, and PRVC. So in pressure control, we set the pressure. The tidal volume varies based on lung compliance and resistance. You can see the parameters on the left. You have our driving pressure, respiratory time, FiO2, and PEEP. So these mainly affect, the first two mainly affect ventilation, and the last two mainly affect oxygenation. And on the right, we have our tidal volume and our minute ventilation, which is our tidal volume times respirate. And this is what the flow, pressure, and volume graphs look like in pressure control. So in the flow, you can see that it peaks very quickly and then gradually decreases. And then you get your expiration, and it's the same thing, it's very constant. And here you can see our pressures that it peaks very quickly and plateaus at a specific pressure. So that's our PIP. And then you have our plateau pressure here, and then the driving pressure, which would be around here, minus the PEEP. And our target, again, is less than 15. So you can see during the whole inspiratory cycle, it maintains the pressure. And the volume varies around the whole inspiratory cycle. So when do we use pressure control? So type 1 respiratory failure, where oxygenation is the issue, ARDS as well. We just want to maintain or improve our mean airway pressure and limit the incidence of barotrauma as well. So the next one we have is volume control, which is kind of like the opposite, where the tidal volume is set based on estimated body weight, and the pressure varies based on lung compliance and resistance. And it's the same parameters, just switched pretty much. And you can see the difference in the flow pressure and volume graphs. So it has like a square flow pattern where you see the flow goes up and plateaus and then goes down directly into expiration. The pressures here look higher and more peaked and tented, and then they drop. compared to the pressures in pressure control where they plateaued and maintain a specific pressure. But here you see the tidal volume immediately peaks to, let's say we set the tidal volume at 550. So you guarantee every breath that is delivered has a constant tidal volume. So when do we use volume control then? The opposite is type 2 respiratory failure, COPD. It's optimal when ventilation is the key issue and guarantees a constant minute ventilation and tidal volume, but however has a higher risk of barotrauma compared to pressure control. And the last one, which we're all familiar with, is pretty much what we most commonly use, is the pressure regulated volume control. It's basically like it's the best of both worlds of volume control and pressure control. You set the target tidal volume and the measure parameter is the pressure. But in PRVC, the pressures will fluctuate by 2 to 3 centimeters of water per breath in an attempt to achieve the set target tidal volume. So it's ideal for aiming to deliver specific tidal volumes while limiting high peak pressures. And it's the most commonly used mode here in the merge. But it's also staff dependent as well. It limits the chance of barotrauma and maintains adequate minute ventilation, tidal volume, and pressure. And the next part I'm going to talk about is the intermittent mandatory ventilation. I'm not going to go into deep about it, but we have our synchronized plus pressure support. It's not very commonly used. I just wanted to illustrate the differences here, as that the set parameters give the same breaths compared to like assisted control, but it allows during expiration for the patient to trigger the ventilator itself, but is not given the same set of parameters. So you can see that the breathing is different here. So the flow is different when the patient triggers his breath. Pressures are different, the volumes are different. We don't often use it, and honestly, like from the staff that I spoke to in ICU, they rarely use it now. And lastly, I'm going to talk about the spontaneous modes. So it's purely patient-triggered breathing. It's ideal for short-term intubation. So it's ideal also for emerge, post-operative patients, or weaning patients off of long-term ventilation. And I'm just going to talk about pressure support. And we don't often use volume support. CPAP is pretty much the same CPAP we use in non-invasive ventilation, but the patient is intubated. So it's ideal for patients that are able to maintain their own respiratory drive and they don't require elevated doses of sedation. We have to make sure that this patient is not on a paralytic, or, for example, if he's not on a toxidrome that limits his respiration or depresses his respiration. And these are the set parameters that we use for pressure support. So we adjust the pressure support, the Peep, and FiO2. And the rest we get is from the measured parameters, so tidal volume, minute ventilation, and respirate. It's important that we maintain a minimum Peep of 5 centimeters of water to match the intrinsic Peep, because once you place an ET tube, you lose the intrinsic Peep. And losing that can decrease functional residual capacity. Any questions before I move on to the next section? I'm going to take that as a no, Jake.
Yeah, correct.
All right. So I have no idea why I chose this picture, honestly. Like, I'm pretty sure at the time I had a joke in mind, but I don't remember what it is. So,
It's a good one.
Thanks. So the complications of a ventilator. So I'm going to divide them into pulmonary and then systemic. So pulmonary complications include barotrauma. So you can get a pneumothorax, sub-Q emphysema, pneumomediastinum, and pneumoperitoneum. Alveolar level, you can get atelectatic trauma, biotrauma, and polytrauma, so it's the alveolar overdistension, which then in turn can lead to villi or valley. So the difference between villi and valley is ventilator-induced lung injury. So we know that the ventilator is the cause of the lung injury, but valley is associated lung injury. So we don't know if it's purely based on the ventilator or an underlying lung pathology. And lastly is ventilator-associated pneumonia. So basically, if you think about it, all the pressure and the tidal volume that's expanding the alveoli can release inflammatory mediator cells and cytokines, which leads to further inflammation, ends up leading to a villi or a valley. Systemic, so GI, we are at higher risk of stress ulcers in the first, once you exceed the first 48 hours of intubation. There's also an increased risk of AKIs, increased intracranial pressure, systemic muscular weakness. As you can imagine, the patient's immobilized for a long period of time and under sedation can worsen their immune system as well. So they're more prone to get nosocomial infections, ventilator-associated pneumonia. All right, so I'm going to move on to the cases now. So I just have a couple of cases. I'm going to present the case, and whoever wants to tackle the case, just let me know. So the first case is a 32-year-old male, altered mental status, GCS 5 out of 15. Brought in, found next to the ground, next to empty pill bottle, alcohol, had minimal response to naloxone, and you decide to intubate with rocuronium. So what would you like to do? Patient's already intubated.
I want to fully control the ventilation because there is some intoxication and maybe respiratory arrest.
Okay, so any specific mode that you want to use?
I think the last mode you already explained about. I forget the name, sorry.
No, that's fine. So probably in Emerge, we're going to keep him on PRVC. And don't forget that we intubated him with rocuronium. So he's going to be paralyzed for a good bit. So we don't want to keep him on pressure support just yet. So we put him on PRVC. And then we can measure the end tidal volume. Once he's able to breathe on his own, we can switch him to a pressure support and try to wean him off the ventilator if that's needed. And then if the end tidal volume shows that he's hypercapnic, that means that patient is now breathing on his own on pressure support. So we'd have to switch him back to a PRVC. So we get his ABG. So it shows that he's like really acidotic. His CO2 is high. His PaO2 is 143, but you can expect that because he's probably been on high flow oxygen since he came in the Emerge, and his bicarb is low. So this ABG like kind of shows mixed respiratory and metabolic acidosis. So the good thing about assisted control modes is we're able to address the respiratory acidosis at least. So this patient has a lot of CO2, kind of basically want to wash it out. So we want to maintain a high rest rate for this patient and minute ventilation. So that would address the respiratory acidosis component. However, like when you have a metabolic acidosis or alkalosis, the most important part is to treat medically. You can compensate short-term, like for example, the metabolic acidosis by either increasing the tidal volume or respiratory rate or driving pressure. You don't want to increase all three parameters all at once. That will just shock the system. So you titrate, and you do this for a short term until you're able to treat the underlying condition. So for this patient, just go back. So there's a lot of alcohol. We're not sure what the empty pill bottle is. It would help if I gave you an anion gap, but I didn't. But this patient could be in like alcoholic ketoacidosis, so that needs to be managed before weaning off the ventilator. Thanks, Hamid, for answering. The next case is a 70-year-old male, presents with 4-day history of lower respiratory tract infection, severe respiratory distress, and you decide to intubate. You get his VBG, he's not acidotic, but his PaO2 is low. His PCO2 is okay-ish. You get this X-ray. Who wants to take this one?
You do pressure support, like it's more type 1.
You mean pressure control?
Or pressure control, yes, right, yeah.
Yeah. So pressure control, or actually volume control, but pressure control, according to the literature, is it's most beneficial for these patients who are in ARDS, where oxygenation is the main issue. So you can imagine that the alveoli are just filled with like inflammation and secretion. So kind of need that maintained pressure in order to flatten the secretions and get a bit of gas exchange. You also want to maintain the pressure in order to avoid barotrauma because they're at higher risk. So for these patients, we generally target 8 to 10 of Peep, depending on their hemodynamics, because they're also septic. You don't want to drop their BP too low. So pretty much we use what's called the lung protective ventilation strategy. So this is usually done in the ICU. We use the patient's predicted weight and use a tidal volume of 4 to 6. And like we said, the driving pressure of less than 15 and a peak, initial PEEP of 8 to 10. We can titrate based on the hemodynamics and the oxygenation needs as well. The initial respirate is set to meet the patient's minute ventilation requirements. And then you just adjust the FiO2 and PEEP. I'm making it sound way more simpler than it actually is, of course. That's why we need to go through residency and fellowships to understand most of this. But our goal in PEEP and ARDS is to maintain alveolar recruitment and improve oxygenation and limiting oxygen toxicity. So we don't want to keep their FiO2 high for way too long. We try to adjust the other settings in order for them to be on a lower FiO2. And this is basically a summary that I created just to show you like all the different acid-based disorders and how you can compensate with the ventilator. So like we said, respiratory alkalosis and acidosis are the easiest ones just because the ventilator is doing everything. It's the others that we can kind of compensate for, but we have to treat the other underlying cause. So for take-home points, I would recommend to all the residents that whenever you intubate a patient, discuss with the staff or RT about the ventilator settings and know your parameters. Have a basic understanding of like different pathologies and how they can affect VQ. Understand how PEEP affects hemodynamics. It's very important since most of our patients that we intubate are very sick. Make sure you don't use spontaneous modes immediately after intubation or the patient's on a paralytic, as the patient has no respiratory and he won't be able to breathe pretty much. And just remember that every patient is different, so you kind of have to tailor your strategy towards the patient and what the patient needs. So thank you. I hope it wasn't too much information all at once, and feel free to ask any questions.
Great. Thanks for the summary, Rita.
Oh, you're welcome.
Yeah. Awesome. Okay. All right. If there are no other questions, then we can move on to our last presentation of the day with Dr. Shuo Peng, who will be giving us an ePOCUS lecture from our ePOCUS lecture series over the year.
Hi, guys. Thanks again for inviting me back. Let me just share my screen first.
Oh yeah, Rita, if you can stop sharing your screen.
Sure.
Thank you.
All right. So let's start this. Okay, can everyone see the screen?
Yeah, I can see it's presenter mode. Looks good.
Okay. Very good. I'm just gonna stop my little video because you don't need to see me. Okay, so today on the focus on POCUS, we'll talk about peritonsillar abscess. A little bit of background on peritonsillar infections. So this is something that we see in the emergency quite frequently. We know that this is something that's usually polymicrobial, but most of it are strep infections. A point I just like to make is that this is really a peritonsillar abscess. So unlike tonsillitis, it's really affecting the space between the capsule of the tonsil and posteriorly the superior constrictor muscle of the pharynx, of the pharynx. And like any other type of infection, this is a spectrum of severity ranging from cellulitis to abscess. That being said, traditionally and classically, needle aspiration is both therapeutic and diagnostic. And most of these peritonsillar abscess will resolve with this very simple surgical management. Now, traditionally, we were supposed to aim for the superior pole of the tonsil, because that's where about 70% or approximately 70% of the abscess occur. And if that doesn't work, you're supposed to aim for the middle pole, where apparently a study shows about 30% of abscess occur. And if that doesn't work, you try the inferior pole. So you kind of go blind in 3 different parts, hoping to get a little bit of sample. So a bit of true or false. True or false, and anyone can answer. When aspirating a peritonsillar abscess by landmark technique, direct your needle laterally.
False.
That's right. Yes, false. It's something that I always kind of struggle to memorize. But any good ultrasound guidance would require that you understand a little bit of the landmark technique, because you have to understand the anatomy behind it. So the traditional teaching of aim medially, avoiding advancing more than 1 centimeter comes from the relationship really between the peritonsillar abscess and the internal carotid artery. So peritonsillar abscess are usually, the carotid artery is usually a little bit more lateral and posterior to the peritonsillar space. That being said, the advice of avoiding advancing more than 1 centimeter is extremely conservative to avoid injuring the artery, because the distance actually between the internal carotid artery and the posterior wall of peritonsillar space is about 13 plus or minus 3 millimeter. That being said, if you're trying to avoid more than 1 centimeter from the anterior wall of the peritonsillar abscess, you're really, really not close to the internal carotid artery. That's where really the landmark technique advice came from, really the anatomy. A blind needle aspiration has been found to be very unreliable with a reported false negative rate of 10 to about 20%, even amongst ENT. So these are people who do it a lot more often than we do. And I can imagine that if we had done a study in ED literature, we're probably looking at higher false negative rates. And the reason is, a combination of what we talked about before. You really don't know where the abscess is. Is it the superior pole? Is it the middle pole? Is it the inferior pole? And this fear of always getting to the internal, this very justified fear of really lacerating the internal carotid artery and not really know where it is. Visually makes us pretty shy about really aspirating where the abscess is, and try to avoid really not advancing that far into the abscess, and therefore giving a high failure rate. So why do we do POCUS for this? As I said before, we have a pretty high failure rate of these aspirations. We are looking at a structure that's pretty close to an artery, that's relatively close to an artery. And point of care ultrasound is there to kind of facilitate and to guide you to where to aspirate. It's a bedside app. You can access the machine at the bedside. And in terms of diagnostic accuracy, comes pretty close to CT. So first, looking at clinical impression, this is cited from a study that was done in 2015. The clinical impression is quite poor in judging whether it's an abscess versus cellulitis. CT is very, very sensitive, but not very specific. And I think we see that often, where we see CT shows maybe an early abscess, definitely some cellulitic changes, But, once the ENT or you try to go aspirate, there's absolutely nothing because it really is just a cellulitis, not really an abscess. Intraoral ultrasound is very specific in that if you do see a collection, it really is an abscess, but sometimes it can miss very, very small collections. All right, so let's introduce ourselves to the intraoral ultrasound or the endocavitary probe. The endocavitary probe is a high frequency ultrasound. The ultrasound strip is in a distal part of the probe, as you can probably see on this picture. There's a little small bump on the ultrasound, and that's actually the bump that indicates the probe marker. And the teaching is that you have to keep your thumb on the probe marker to know where the probe is pointing to at all times. And when you're scanning with this endocavitary probe, you always start sagittally, so with thumbs up, thumbs on the on the probe marker. And if needed, you rotate the scan transverse with the thumb now rotating to the left. So this is a very, very quick introduction to the endocavitary probe. When scanning with this probe, obviously, it's very, very important to keep everything clean. So you do need some kind of probe cover. Most of us do suggest that you use just a sterile glove. I use size 10 and up because the thumb and the finger part really fits nicely over the probe itself as a cover, and it's less explaining to do for the patient in terms of what you're putting over the probe to sheath it. And obviously, before putting the glove on, put a bit of gel on the probe just to make sure there's good contact between the probe and whatever you're scanning. All right, it's very important to set up with a nice suction and spray generously lidocaine over the area you're scanning, both for patient's comfort and also to suppress the gag reflex, because it's very, very easy at that using this probe at that sensitive area to really get the gag reflex going. As it says, to use a sterile sheath on the probe. And I like to always start on the unaffected side just to get a sense of anatomy. And you'll see, based on the picture I'll show later on, that anatomy of tonsil when it's normal is very easy to see, but anatomy of a tonsil with peritonsillar abscess can be quite distorted. Again, like any other ultrasound, we want to try to scan and sweep in two planes. I'm not going to go too much into the actual procedure itself and just concentrate on the ultrasound. So this is just very, very brief introduction and brief talk over the procedure itself, but we'll focus more on the ultrasound. So what would you see? What does a normal tonsil look like? A normal tonsil with intraoral ultrasound, this is a sagittal view of a normal tonsil. It's very low echogenicity. You might need to turn the brightness up on your screen just to see it very well. So it looks relatively hypoechoic, not anechoic. It has a bit of striae inside of it, and it has a typical appearance of a lymph node, which means that the center of the structure looks a little bit more bright. And if you put color Doppler on it, it will have more flow in the center of the tonsil. And the exterior or the outside portion looks much, much darker or hypoechoic. It's approximately about 1 to 2 centimeter. And where you see the star is the tongue. So that's what a normal tonsil should look like. And if you're not sure, if you just want to get an idea, the easiest thing is just to take a linear probe and to scan someone's neck. Because when you scan the neck, you'll see some of the cervical lymph nodes, and that's exactly what a tonsil should look like, a normal tonsil. So what does a peritonsillar cellulitis look like? That's normal, that nice small tonsil just looks a little bit bigger. It looks a bit beefier in the sense that there's actually less of the hypoechoic structure, and it becomes a little brighter or a little bit hyperechoic. Again, it's a lot larger. So if it measures about 2 centimeters more, you can think that perhaps it's a tonsillitis and not just a normal tonsil. Again, the tongue is in the right field here. And so what does an abscess look like? This one, again, you have to turn up your screen to see better. A peritonsillar abscess, remember always, it's a peritonsillar abscess. So other than the tonsil may be affected by being, by appearing like it's a tonsillitis, the abscess itself is actually mostly behind the tonsil. So here you see the tonsil here. You see that the field is adjusted to include much of the far field, unlike this one, which is 3 centimeters, you see 3 centimeters deep. This one you see 5 centimeters deep. So here you have the tonsil, here is a ton. And behind the tonsil, you see a collection that's anechoic with debris, which is a very, very typical appearance of an abscess. Remember, abscesses are not cysts. They're not just fluid, you know, without anything enclosed in a capsular space. Abscess is, you know, filled with pus, and pus is not always anechoic. You know, it has a little bit of echogenicity to it. And so once you find where the abscess is, you can measure on your image to see how deep your needle have to go. And in this instance, you have to go about almost 2 centimeters, which is way longer than the traditional teaching of do not advance more than 1 centimeter. Because if you don't advance more than 1 centimeter, you're obviously not getting any aspiration back. All right, so let's take a look at this. Oh, why is it not playing? 1 second. Oh. So is there an abscess or not on this still image?
I don't think so. I'm going to say no.
Yeah, again, these are difficult, right? These are new images. You've never seen this. This is not something that we've taught you often in the past. So this is, you don't really see an abscess. We said, okay, well, this over here, you know, knowing the context is probably the tonsil. We know from the marker on the side, it's about 2 centimeters. It looks very beefy. Looks, you know, it's got different echogenicity structure to it, but I don't see any, you know, anechoic or very, very hypoechoic component that suggests if there's a collection. So this is a tonsillitis. This is what a tonsillitis looks like. All right, what about this one?
Yes.
Yes, this one is a little bit more obvious. Just for orientation wise, the tonsil is actually here. You see that lymph node-like structure, that's the tonsil. So this is a peritonsillar abscess. Again, the abscess itself is next to the tonsil. And if you were to kind of imagine that this is your patient, I have to determine how far you have to advance needle. How far do you think you have to advance needle?
2 centimeters.
Yeah, about maybe 1.5 to 2 centimeters. So if you're winning with the idea that I'm not going to go more than 1 centimeter, you're not getting any of that pus back, right? And hopefully this works. There we go. So one advice about using the intraoral or the endocavitary ultrasound, you see all these artifacts. These are air. These are artifacts caused by air, which means that sometimes it makes your scanning a little bit easier if you just put a little bit of gel outside the sheath. Or what I do is I kind of just wet the outside of the sheath with a bit of water, just to avoid putting lots of gel there and having the patient aspirate on the gel. And that can help to move the air bubbles away. That being said, these are very real possible picture that you will see that's not completely optimized because it's difficult to optimize these type of ultrasound. Do you see an abscess or not?
Yes.
Yeah, right. Here, you can see that there is a relatively more hypoechoic, and it looks like a little collection here. And that's probably the tonsil itself. That being said,
collection?
Yeah, sorry?
Is there like a second collection just behind slightly? Yeah.
Yeah, so again, abscess are not just one, most of them, you know, we hope that it's just one pocket, right? But sometimes you can have two pockets or more of abscess, or just abscess separated by a septate that's really communicated with each other. So I agree with you. There seems to be maybe more pockets, or maybe it's communicating together, these two. That's over here. That's what you're referring to.
Yeah, exactly.
Yeah. So, well, let's say to get to the largest pockets, right, we are looking at probably a little bit more than 1 centimeter from the top of the screen, which correlates to the anterior wall of the tonsil. Good. All right. So now that we know this amazing tool, what are the applicability of it? So how often, have anyone done these type of ultrasound, endocavitary for peritonsillar abscess?
I have not.
Yeah, I don't think most people have, just because, you know, the applicability of these type of ultrasound is pretty limited. It's a great tool, and it really lets you see very closely the target. But when you have a patient who's presenting with peritonsillar abscess who have trismus, it's kind of hard to fit that probe inside the mouth. And on top of that, you know, endocavitary ultrasound is not available in all centers. You know, it's available at the Jewish General. It's not available, I know of, at St. Mary, and it's not available at Lakeshore. And I don't think it's available at RVH. Last time I heard, they took away the endocavitary ultrasound because there is no cleaning protocol. And it's not available by MGH. So of all the center that you rotate through, there's one where it's available. Availability is a big issue. That being said, again, you can't use it for dynamic guidance. Once you fit the ultrasound in there and the suction catheter in there, there's absolutely no space for the needle. So there's a few, a few barriers in using the endocavitary ultrasound. And what about transcutaneous ultrasound? You know, the lymph node, the tonsil itself is relatively superficial structure. And so can we see it through transcutaneous? So there's only one study that compared transoral to transcutaneous ultrasound. And it shows that transcutaneous ultrasound has pretty reasonable sensitivity and pretty good specificity, identifying and confirming the presence of a peritonsillar abscess. So how do we do this? So the transcutaneous, you can either use an abdominal probe, which I like a lot actually, or a linear probe. And you kind of fit just parallel to the jaw with the one end of the ultrasound at the angle of the jaw. And you're aiming up, aiming for the tonsil, which you can kind of visualize to be here. Again, flipping the image upside down, because that's what you're seeing with the ultrasound. The first thing that you'll see is a gray structure that's the submandibular gland. And superior to that, you'll see the tonsil with the tongue that's over here. This image also shows that posterior to the tonsil, posterior lateral to the tonsil, you can use Doppler to identify where the carotid artery is. All right, so let's go through some image recognitions. So this is what a normal tonsil looks like. Again, this is a submandibular gland. This is the tongue itself. And this, again, is the tonsil. Again, tonsil looks slightly hypoechoic. It's very small. It has a bit of internal structure to it. And it's, as I said, it's usually between less than 2 centimeters, but usually about 1 centimeter in its size. What does it look like when you have peritonsillar cellulitis or a bit of tonsillitis? The structure, the tonsil itself becomes a little bit more bigger. The internal structure of the tonsil becomes a little bit more echogenic, but you don't see a collection per se beside the tonsil. And this is what a peritonsillar abscess looks like. So you have the left tonsil here. That looks very striated, very, very heterogeneous, and very kind of bright, indicating that there is a degree of tonsillitis inside the tonsil itself, and the abscess is behind it. All right, so let's go through some image recognition. Do you see an abscess?
Yes.
Yes, right? I also see an abscess. This one looks like it's actually inside the tonsil. And it looks like it's around. Can't really stop this. Looks like it's more inside the tonsil. It's a tonsillar abscess, which also happens. Yeah, but it's around here as well. All right. What about this one? Do you see an abscess?
Yes. But it's very adjacent to the vessel, this one.
I'm sorry?
Very adjacent to the vessel.
Yeah, it's really quite close to the vessel itself, right? You have the tonsil somewhere probably over here, and then the abscess collection here. The good thing about subcutaneous or surface ultrasound is that you can actually use it for dynamic guidance and see your needle going into the abscess and knowing how much to advance. You can keep the color Doppler in place and just use it to guide you away from the vessel itself. It is quite close to the abscess. You're completely right. All right, last but not least, what about this one? It's a still image, so I know it's a little bit harder to judge.
I would say it's more of edema, like tonsillitis, rather than a clear abscess. I'm not sure.
Yeah, so the text itself and the article itself identify this as a tonsillitis without an abscess. Again, just to identify the structure, you have the subinterbural gland, you have the right tonsil, and you have the ton over here. This is a very, very nice image. Sometimes you don't see something so clearly defined. Again, so you think that maybe this is a collection over here, but I think maybe by scanning that kind of becomes less of an issue. But the tonsillitis itself means that the tonsil looks bigger. It looks a little bit more brighter with a bit more heterogeneity to it. And this is an example of a kind of tonsillitis or cellulitis without any abscess. If you want to see abscess and if you're looking for abscess, I recommend that you actually increase your depth to about 5 to 7 centimeters to look for that abscess behind the tonsil, and to really sweep to get an idea of where it is. All right, so that's about it for the presentation. Again, it's introducing a concept that we don't use very often. It is images that you're not used to seeing at all. These are not very similar to the abdominal ultrasound that we frequently do. And we're looking at soft tissue, soft tissue structures, which can be very contorted in different infectious etiologies. I would encourage you, if you have chance on your next shift, to just take a look at your own tonsils to see what it looks like, and to have that picture in your mind, and that can help you identify what a tonsillitis or a peritonsillar abscess will look like.
Great. There was a question from the crowd earlier. Just, is there a minimum abscess size that would be worth aspirating, like, weighing the possible complications versus symptoms?
So that's a really, really good idea. That's a really good question. And I don't really have an answer for that. I know for example, there was a patient that I had, which I really didn't think was worth aspirating, had a peritonsillar abscess or early abscess that I didn't see on ultrasound at all. And that got picked up on CT. That's 2 millimeters by 4 millimeters. So quite small, which ENT thought it was worth their time to drain, but they didn't drain anything. So I don't have a great question for that. I think it's the same thing as if you see a cellulitis with an abscess. If it's very, very small abscess, is it really worth it to put a needle in it? And there's really no great cutoff. It's just a matter of clinical judgment.
Great. And another comment just regarding for the submandibular view, like the patient's body habitus could be limiting in that view. Like do you find that gets in the way?
So yeah, I mean, absolutely. So that's why I kind of tend to prefer using the curvilinear, because you can kind of decrease your view. It's made to go through tissues. Most people, unless you're very, very heavy, don't really have that much tissue over here. You can have a little bit more kind of fatty chin, but it's not the same degree as if you're trying to go get to, a right upper quadrant view, and there's, pannus in the way that you kind of have to really physically move around. So it's not that much of a limiting factor. Smaller is always better in ultrasound, but it doesn't really, exclude the use of transcutaneous ultrasound in someone who's a little bit bigger.
Great. Any other questions? Okay. Thanks so much. That was great. Really, I had not seen those views before. So that was awesome to see.
All right.
Great. Okay, everybody. So yeah, shorter rounds today, but thanks so much for being here. We do have recess hour, I think at 1:30 today. And for the residents. And yeah, next week is RBH day. So it should be good. All right. Thanks, everybody.